Hi everyone, Michelle Lyons here. A couple of questions came up in different Facebook forums during the week, and I thought instead of just writing on my phone, I thought it'd be useful to put a video together, and then what I'll do is I'll put this into a blog post with some of the references that I'm going to talk about. So the two questions that came up during the week were questions about the difference between tone and strength, particularly when we're talking about the pelvic floor muscles, and if pelvic floor muscles are hypertonic or overactive, does that necessarily mean that they're strong? So tone is a word that I think we've borrowed from our colleagues in neurology, where they talk about the tone of a muscle being upregulated or downregulated, maybe in the case of a neurological issue like someone has a stroke or has multiple sclerosis or cerebral palsy. That can affect muscle tone. When we're talking about the pelvic floor muscles, we sometimes interchangeably use the descriptor hypertonic, meaning overly contracted or overactive, or hypotonic. And sometimes we use hypotonic when we mean weak or neurologically impaired, maybe if there's been some damage to the pudendal nerve, for example, maybe using forceps during stage 2 labor. So overactive pelvic floor muscles are not necessarily strong, because a muscle can be held up like this. I can have my upper traps up by my ears in a state of overactivity. It doesn't necessarily mean that they're strong. In fact, overactive muscles might be functionally weak. So in the case of the pelvic floor muscles, where we want the muscles to have a nice relaxed tone or state of activity, so that they can close and lift, they can relax, they can lengthen and come back to a nice relaxed tone again, that resting place. If we've got a nice set of relaxed pelvic floor muscles, it means that they've got that full range of motion to close and lift, to protect against any increase in intra-abdominal pressure like a cough or a sneeze or going from sit to stand. But if they're already up like this, there's nowhere for them to go. So those muscles might actually be functionally weak muscles. So muscles that are overactive are not necessarily strong muscles. What we want to think about is what are normal pelvic floor muscles? So normal pelvic floor muscles, and this is based on some of the work that the International Continence Society have done, are muscles that can contract, they can relax, they can lengthen, and they can come back to a nice relaxed place again. Underactive, or what we might call hypotonic pelvic floor muscles, these are going to be weak. They're going to be too weak to do what we need them to do. So that's where we might see stress incontinence. We might see some prolapse going on in that situation, coupled with some soft tissue and connective tissue defects. When we talk about overactive muscles, these are muscles that are held in this state of readiness, contraction, tension. And these muscles can test weak because, again, there's nothing left in the tank for them to go. Why do muscles become overactive? Specifically, why do the pelvic floor muscles become overactive? Sometimes it's pain. If there are pain syndromes like bladder pain syndrome, endometriosis, that can cause overactivity of the pelvic floor muscles. If we've got pregnancy-related pelvic girdle pain, that can cause overactivity of the pelvic floor muscles. If we're stressed, if we're in a state of anxiety, that can cause overactivity in both the upper traps and the pelvic floor muscles. There's a study that I've put on the board here by Vanderveld in 2001, and they looked at women who were watching sexually threatening movies, and they had them hooked up to surface EMG biofeedback, and what they found was that these women who were safe in a theater, but they were watching scenarios where other women were in danger, they registered increased muscle tension in both their upper traps and their pelvic floor muscles. So fear, anxiety, stress, trauma, pain, asking muscles to do things that they're not designed to do, all of these things can contribute to overactivity in the pelvic floor muscles. What else did I want to talk about? Yeah, so pain and anxiety. I also wanted to talk about another question that was coming up during the week on Facebook about pregnancy-related pelvic girdle pain, because these are both related topics. Because sometimes you can have overactivity in the pelvic floor muscles in pelvic girdle pain during pregnancy. Why? Could it be stress? Could it be trauma? Could it be because we're asking these muscles to do things that they're not designed to do? So if you've joined our pregnancy wellness course, you'll know that one of the interviews that's in there is one that I did with Dr. Sinead Dufour, who is a Canadian physiotherapist and researcher. And we talked about pregnancy-related pelvic girdle pain, how it's not just a biomechanical feature. And Sinead wrote a great paper, which I'll put a link to in the blog post below, called Pregnancy-Related Pelvic Girdle Pain, Embrace the Evidence and Move Beyond Biomechanics. So there's a couple of key points that I just want to read from this paper because I think she says it very eloquently here. Imagine you are 32 weeks pregnant with your first child and you start to have pain in the low back and pubic area when you change position, you sit or you stand for longer periods. The pain makes it very difficult for you to function and you worry about whether you can continue to work and manage your household. You're also concerned about the upcoming birth of your baby and whether you'll be able to care for your baby, an often seemingly overwhelming task without having to deal with pain. Now imagine you've seen your healthcare provider and have been told that your pelvis is separating because of the pregnancy hormones and that you need to put up with this until after you have your baby, as it will probably get better afterwards. Imagine you are also told to be careful because your pelvis is unstable. Now, if we've talked before about this, you'll know I have a big problem with people telling women that we're working with that their pelvis is unstable. Okay, your pelvis is the most stable part of your body. Unless you've had major vehicular trauma, your pelvis is stable. More on that anon. She goes on to say, these are common words of advice or explanations pregnant women with pelvic girdle pain receive from their healthcare providers, including physiotherapists. These words are not substantiated and do more harm than good. So she goes on in the paper to talk about the causes of pelvic girdle pain being multifactorial and having a large connection with stress levels, poor sleep, disrupted gut health, any previous history of trauma, any job dissatisfaction. These are all strongly associated with pregnancy-related pelvic girdle pain. It is not that the pelvis is unstable or is going out of place. It is almost impossible for your pelvis to go out of place. Now, can your pelvis become sensitized during pregnancy? Absolutely. If you have a look at this little model here, okay, so you can see towards the end of pregnancy, you can see how the baby is kind of just sitting down on the front of the pelvis and kind of hanging off these abdominal muscles here. If we haven't got good strength, good functionality in our glute med and our glute max, then what can happen is the pelvic floor muscles and the adductor muscles on the inner thigh can start to hold on for dear life because they're trying to do the job of holding everything together. Now, if we already know that increased stress and anxiety from the Van der Velde paper that I talked about can already feed into overactivity of the pelvic floor, and we know from Men's paper from 2017 showed that most women with pregnancy-related pelvic girdle pain have overactivity of transversus. You know, these are small muscles trying to support a substantial increase in body weight, whether we're talking about the baby, the amniotic fluid, increased breast size. So it's important that we do acknowledge that structures are sensitized during pregnancy, but we don't just focus on the biomechanics of what's going on. So what are we going to do about it? I'm going to paraphrase Gregory Lehman, the Canadian physio and chiropractor here. We want to calm things down, build things up, and encourage resilience. Does that mean that we don't use manual therapy? No, we do use manual therapy to calm down the nervous system, to restore confidence in movement, and then we're going to apply an appropriate exercise strategy that is going to focus on de-stressing structures that are sensitized and building up structures that maybe are not fit for purpose at the moment. Movement is medicine. You know, what we want to do is we want to make sure that we're calming down the brain and the nervous system. We're being very respectful. There was a lovely paper that was done, let me see the year. It was 2017, And they looked at how stress reduction therapy improves symptoms of pregnancy-related pelvic girdle pain and reduces salivary cortisol, which is one of your key stress hormones. So providing calming strategies, providing strategies that are going to calm down the pelvic floor and the adductors and transversus, build up those big global movers like glute med and glute max, come up with ergonomic strategies for getting in and out of the car, getting in and out of the shower, getting dressed. All of those things are going to calm down that level of stress in the brain. They're going to calm down sensitized structures in around the pelvis and the lower back, and they're going to encourage women to get moving again and to develop some resilience and prepare them for labor, delivery and baby care afterwards. So what I'll do is I'm going to put all of this into a blog post with links out to some of these references here that I've just talked about. Have I hit all my markers here? I think I have. Pelvic girdle pain, sensitized structures, so work on your stress levels, gut health, sleep, look at the ergonomics. What we're seeing, I think, with pregnancy-related pelvic girdle pain, what the literature seems to support is that we shift away from a purely biomechanical approach and we look at the whole person and really look at both top-down approach as well as a bottom-up approach. So hopefully that clarified a little bit about the difference between hypertonic and hypotonic, overactive, underactive, strong, weak pelvic floor muscles, but then how all of that can play into pregnancy-related pelvic girdle pain.